Good morning, everyone. My name is Asma Khalila, and I'm a professor of fetal medicine at St. George's Hospital. I'd like to welcome you. This is our 9th webinar of the Twin Trust Center for Research and Clinical Excellence. So this center was set up a few months ago. And that's supported by the Twin Trust. It's based at St. George's. It's the first Twin Trust Center for Research and Clinical Excellence. And we're doing a number of activities, including educational, including research, and including also trying to improve patient outcomes and experience. And the Twin Trust is a UK national charity for twin and multiple pregnancies, and I welcome you to go to the website. It's offering a large number of CPD, so stuff that's really useful for healthcare professionals and, of course, for more importantly, obviously, for the patients. So I welcome you to go to the website. This, as I mentioned, this is the 9th webinar. A common question is that how can I access this webinars? They are on the Twin Trust website and often get publicized on social media like Twitter platforms and so on. I'd like to tell you that these webinars are recorded and therefore if you are not keen for your picture to be seen, or please don't switch on or turn on your video, because I said that these webinars are recorded, and that's why we are insist on the fact that you are registered in advance, so at least you have already provided your details or consent to join the webinar. Many of you asked about certificates, and we said that if you have registered, you can have certificates, and if you contact us, we can certainly get that to you. As I mentioned, the webinars occur every 2 weeks, and they happen on Saturday at 11 o'clock London time. We do have some international people joining as well, so welcome. So the world has become really a small place with no boundaries nowadays, with all the media and the digital communication. I would like to welcome, we have 3 excellent speakers today. The webinar, they focus on TAPS, or twin anemia polycythemia sequence, which is a topic that unfortunately until now it can be quite controversial, certainly in the UK. And that's why I think we have Femke Slachecki, who is a fetal medicine consultant in Leiden, in the Netherlands, which is a center for fetal therapy. And she really have extensive experience with TAPS. I think she's probably not published. She's the person who published most on twin anemia polycythemia sequence, and she's gonna talk to us about her experience, both clinical and also the research. Followed by Veronica Giorgioni, who's one of our fellows, who is going to talk about some of the perinatal outcomes, and she's done recently a meta-analysis, so she's going to share some of the data. And then followed by a very interesting case, so Laura Newell, who's also one of our fellows. She's a fetal medicine consultant in Belgium, and she's spending time with us at St. George's here. So she's going to present a case on TAPS, and then we'll follow that by discussion. The webinars, we plan to have them about maybe an hour and a half, because I think it's a bit tedious to be in front of the computer for that long. I think we will get bored. So I'm planning to have it, hopefully we finish by about 11:30. But let's see how it goes, because sometimes the discussion was very interesting. There was also questions, and we carried on until 1 o'clock. But I'm hoping that we finish by about 11:30. Okay, so I think I will stop here, and I will invite Femke to start her talk.
Well, Asma, thank you very much for your kind introduction and your kind words. Well, TAPS is one of my hobbies, indeed, and I started as a PhD project, and well, I keep on continuing doing research on TAPS, and as you said, it's a complication in monochromatic twins that does need extra attention, and a lot of people are not aware. So I'm really happy that you invited me for this webinar, and I can share our knowledge from Leiden University. So what I will do in this presentation in the coming 30 minutes, I will try to do it structured and tell you something about the pathogenesis, the antenatal diagnosis, the postnatal diagnosis, short-term outcome and long-term outcome, and then antenatal treatment options, and then see how we go from there. So let's start with the pathophysiology. It's a complication in monochromatic twins. We always have, well, we can have multiple triplets or multiple pregnancies, including triplets, but I will focus on twins. So there's a disbalance in fluid, or a disbalance in transfusion. And if you have transfusion through large anastomosis, what you will, then you will have twin-twin transfusion syndrome. But if you have disbalance through small anastomosis, then you will develop twin anemia polycythemia sequence. And it can occur spontaneous, or it might occur after laser treatment for TTS, and then we call it a post-laser TAPS. So what is TAPS? So TAPS is caused by transfusion from the donor to the recipient, and it's causing an anemic twin and a polycythemic twin without the typical amniotic fluid difference as you see in TTS. And the pathophysiology is based in the placenta, and what we have in TAPS placentas is that we have very small anastomosis, as you can see in this placenta. If you look very quickly, you might think that there's no anastomosis at all, but if you look more in detail, then you see that there's a really tiny anastomosis, and then you see green on the right side going to a pink vessel. So on this picture, blue and green are arteries, and pink and yellow are the veins. And as you can see from the right side of the placenta, there's a tiny artery going to a pink vein, causing twin anemia polycythemia. So it's a small VA. This is another placenta. This is after laser treatment for TTS, and we see the laser line which are circled, and then between these small laser lines you see just one tiny vessel, and that was causing twin anemia polycythemia. Even voor de zekerheid. So what's the incidence of spontaneous TAPS? We see it in monochromatic twins, we see it up to 5%, 3 to 5%. And if we see it after laser treatment for TTS, so 10% more or less from the monochromatic twins develop TTS. And of those 10%, 2 to 16% develop twin anemia polycythemia. The 16% was found before we did the Solomon technique. I will tell you a little bit later on. But the Solomon technique we reduced the incidence of post-laser TAPS to only 2 to 4%. So how do we diagnose TAPS? So what we look at the difference in MCA-PSV. So we measure the middle cerebral artery in the brain, and in the anemic twin we see a high MCA-PSV, and in the polycythemic twin we also measure the MCA-PSV, and we see a low MCA-PSV. So there's a discrepancy. And for a second stage, the discrepancy is increasing, so it becomes higher in the donor and lower in the recipient. And here we see an example of a TAPS case. So first you have normal flows, that's the dots that you see. And if you continue, you see that the difference is getting bigger. And previously we had what we reported in fetal diagnosis and therapy in 2010. We reported that you to have a TAPS, you should have an MCA-PSV higher than 1.5 mom or below 1.0 mom for stage 1. For stage 2, it would be more than 1.7 and less than 0.8. And for stage 3, You see cardiac decompensation, so you see abnormal flows. You can see that in the ductus venosus, so an increased pulsatility index or reverse flow in the ductus venosus, absent or reverse flow in the umbilical artery, or pulsatile flow in the umbilical vein. And stage 4 would be hydrops, and as in THDS, you will see more frequent hydrops in the recipient. You see more frequent hydrops in the recipient, but in TAPS we see more hydrops in the donor because of the severe anemia. And stage 5 is fetal demise of one or both twins. So in 2010 we made an antenatal classification system, as I said before. So stage 1 there would be an increased MCA-PSV in a donor more than 1.5 and less than 1.0 without signs of fetal distress. For stage 2, it would be above 1.7 and below 0.8. Stage 3, there would be signs of cardiac decompensation shown in abnormal Doppler measurements. Stage 4, hydrops, and stage 5, fetal demise. And then the Delphi procedure was performed by ASMA. And we asked all experts in the world what we think we should use for diagnostic criteria. And then we asked what shall we use, and this was published in Ultrasound. And then we see there should be the MCA-PSV above 1.5 or below 0.8, or a difference between the cerebral artery peak systolic velocity of more than 1.0 mom. So, and then I would like to continue. So what we did, we tried to look at all our TAPS cases in our own center, and what we found in during just our working days, just in clinic, we saw that there are cases with severe TAPS that didn't meet those criteria. So this would be the previous cutoff, so be above 1.5, below 1.0. But then we also saw a delta MON of more than 0.5, so not the 1.0, but the 0.5. And then we also saw that these children had, after they were born, they did meet the postnatal criteria. So there were signs of anemia and polycythemia. But it doesn't meet the previous criteria because the recipient in this chart is not below 1.0, but the donor is high. But we also had other cases. What we had is that also there were donors that had MCA-PSV measurements that did not come above 1.5. And there were recipients that were very low. And also, these had severe signs of TAPS. So that's why we just go back. So that's why we proposed a new antenatal classification system. It's only to diagnose TAPS. It doesn't say that we at what stage we should do treatment. I will tell you that later on. But we think it's very important to look for a delta, and also if it's only a difference of 0.5 mom, keep a close eye on those twins, because they cannot. It could be that there are no signs of fetal distress, but it might develop. And then for stage 2, we used a delta of 0.7 mom, and then stage 3, 4, and 5 are the same as the previous described stages. So what we also did is we looked for signs of TAPS on ultrasound. So not only the MCA-PSV, but look for are there additional signs to see whether the twin is anemic or whether to see the twin is polycythemic, to have extra information on that. So what can we look for? In the recipient, we can look for a starry sky liver. And what you see is that you see echogenic spots in a liver. And one of the reasons why we think this is happening is because of the polycythemia, that the liver parenchyma becomes a bit darker, and all the vessels that you see in the liver become a bit more echogenic because of the polycythemia, and that's why you see a little bit darker liver with bright spots like stars in the sky. That's why we call it the starry sky liver. And in the donor twin, we can see cardiomegaly as a sign of anemia, and that's what we can look for. And the other thing, sometimes you can also see a little bit of pericardial effusion, And the other thing that we were looking for in the donor is, or in both twins, is the color difference in the placenta. As you can see, in the recipient, it's a bit darker, and in the donor, it's a little bit more echogenic. The other thing that you sometimes see is that the part of the donor also becomes a little bit hydropic. So it's also enlarged and brighter on ultrasound. So those additional things you can look for, and it might help you to find a TAPS. And how often do we see these changes? So in 66% we saw a starry sky liver, in 70% we saw cardiomegaly, and 44% of the cases we saw the dichotomy placenta. So how do we diagnose TAPS postnatally? We have a donor and we have a recipient. We collect blood samples, and we always suggest to do that the first sample from the umbilical vein. So just from the placenta, so you don't need to take samples from the children. If they are born extremely premature or premature, then probably the neonatologist will also take a sample. Then you can request for some extra testing and what we're looking for is the hemoglobin and the reticulocyte count. And we always do a combination of these two, because only hemoglobin tells you a little bit whether the donor recipient is anemic, but that doesn't tell you about whether it's acute or chronic. And what's typical for TAPS is that this is a chronic disease, a chronic complication in monochronic twins, because it was an ongoing transfusion for a longer period. And that's why the donor has a low hemoglobin, but a high reticulocyte count, because it was trying to correct its anemia. So again, this placenta with this really tiny vessel, and that's one of the other things that we look for postnatally is look at the placenta. Because if you have placenta with big anastomosis on top, then it's more likely to be an acute transfusion from the donor to the recipient instead of a chronic transfusion through tiny anastomosis. So to meet the antenatal diagnosis for TAPS, you need to have an anemia and a polycythemia. And then one of the other two. One could be you have an increased reticulocyte count ratio, more than 1.7, or you have really tiny anastomosis on the placenta surface, which are less than 1 millimeter. And that's to distinguish between acute peripartum TTS. You also see a pale and a plethoric baby in this slide, but this was an acute TTS. And then again, you have a hemoglobin difference of more than 8.0 moms per liter. I don't think it's moles, please, it's grams per liter. But the reticulocyte counts in both twins were normal. And there were large anastomosis, and a lot of times you see also a large AA. So hemoglobin difference, it's easy to measure. The reticulocyte count ratio is often not measured, and the placenta is often not injected. So one of the other things that you could do is just after birth, and everybody can do that. So if you're in your hospital and you see a pale and you see a plethoric twin after birth, just turn around the placenta and look at the maternal side, and then you will see a pale part for the donor and a plethoric part for the recipient. And here you see the different gestational ages at 25 weeks, 30 weeks, 35 weeks. And you see the patients that are the twins that belong to these placentas. And what we did, we made with image J, if you want to do a proper calculation, you could do that and then measure the CDR mode. So uncomplicated twins have the same color at the maternal side. Acute peripartum twins also have a complete same color at the maternal side, and in TAPS you do see a pale and a plethoric part. So how do these twins do? And we looked at both cohorts about spontaneous TAPS cases and post-laser TAPS cases. This was a very large international registry where we asked a lot of centers to join to look at the perinatal mortality and morbidity. And then we saw in spontaneous TAPS, the perinatal mortality is 9%, and in post-laser TAPS, it was 19%, where 13% were donors and 28% in the post-laser, and recipient 5% and 10% in the spontaneous and the post-laser TAPS. And the risk factors were being a donor, the TAPS stage that you had, or the gestational age at birth. Then severe neonatal morbidity, which includes RDS, PDA, NEC, ROP, and SCI. And we saw it in 33 to 40%.
Ik zie één optie. Wil je deze proberen?
Preterm delivery was 32 weeks, and severe cerebral injury was reported in 4 to 11%. And again, risk factors were the stage of TAPS and the gestational age at birth. As in all studies that we do in twins, gestational age at birth is a very important risk factor. The more premature you are, the more risk of adverse outcome. But also in these studies, we showed that TAPS stage is also contributing to, is a risk factor. So the long-term outcome of these children, so severe neurodevelopmental impairment, that would be an IQ score below 70, bilateral deafness, bilateral blindness, cerebral palsy. In total, in the post-laser TAPS cases, we saw it in 9%, in 5% of the donors and 11% of the recipients. So this was a study we performed on all post-laser TAPS cases, and there was no statistical difference between donor and recipient. You might think that according to these numbers, but it was not statistically different. And then we did a severe neurodevelopmental impairment study in spontaneous TAPS cases. And then again, we saw a total of 9%, but we did see a difference between the donors and the recipients, which is very typical for the spontaneous TAPS. Donors are more at risk to have an adverse outcome. So in short term, like I showed in the previous slide, but also long term, donors have a higher risk of impaired outcome. And the other thing which we found is in TAPS donors, in spontaneous TAPS donors, that they have more cognitive impairment compared to the recipients. And what was very interesting, and we didn't expect this, is we do see much more bilateral deafness in TAPS donors. So 15%, they were auditory neuropathy. So there was nothing wrong with their inner ear, but it had to do, it was cerebral injury, so auditory neuropathy. And what's very important is if you screen those babies, in the Netherlands we have standard screening for impairment, hearing impairments, but you need to do the specific algo screening to screen for auditory neuropathy. That's this screening that we do, so you make sure that you screen for auditory neuropathy. Then we go to the treatment options. So expected management, so keep a close eye on your twins, check how they're doing, whether TAPS is progressing. You could deliver them preterm. You could give them an intrauterine blood transfusion in the combination with a partial exchange transfusion. So an intrauterine transfusion, for example, if the placenta is anterior, you go into the umbilical vein and you can give a transfusion to the donor. And in the same setting, you could do, not simultaneously, but later on, you could do so a partial exchange transfusion. So you take out the blood and we'll put back saline. And why would we do a partial exchange transfusion? Because we're giving the donor extra blood, but what will happen, because you're not treating the cause, the blood that you give the donor will go to the recipient through these tiny anastomosis on the placenta, which makes the recipient even more polycythemic, and then it might be at risk for thrombosis in limbs or severe cerebral injury. That's why we also perform partial exchange transfusion. Another option is laser treatment. So fetoscopic laser coagulation. And now I'll talk a little bit about the Solomon technique. So what we do with a fetoscopic laser coagulation, as in TTTS, you always enter the sac of the recipient, but in TAPS, they both have more or less normal amniotic fluid amounts. So what you do, you will enter the sac of the twin where you think you're best able to reach the vascular anastomosis, where those vessels meet. And in this image, you see it's in the recipient, but it could also be in the donor. But you need to create a TTS. So what you need to do, you need to infuse amniotic fluid. And sometimes it's enough to only infuse amniotic fluid in the sac that you're going to enter. But sometimes it's also necessary to extract amniotic fluid from the other twin to make sure that you can look through the intertwin membrane. As you see here, the intertwin membrane is flattened on the surface of the placenta, and then it's much easier to see the vessels. If the intertwin membrane is still wavering around, you cannot look through the intertwin membrane and you cannot find the vessels. So here we see a placenta which was lasered using the Solomon technique. And with the Solomon technique, what we do after we coagulated the individual anastomosis, and so the spots where we had anastomosis, afterwards you draw a line from one placenta margin all the way to the other, so to be sure that all tiny anastomoses in between are also coagulated. Now another treatment option is selective reduction, and you can discuss that with parents depending, of course, on their preferences, and also maybe depending on whether one of the twins already has congenital abnormalities or is extremely ill or has severe anemia with possible signs of brain damage or other complications. That's when you could discuss selective reduction. So we did a large international TAPS. We had a large international TAPS collaboration, the TAPS registry. You can see that here a lot of hospitals were collaborating in this registry. And then we looked for 422 TAPS twins. And here you see the distribution of the twins. As you can see, we had a lot of cases. It is because we already started looking at TAPS quite early, and that's why we collected so many. And the other reason why we collect so many is we have a beautiful geography in the Netherlands. We are the only fetal therapy center in the Netherlands, so all patients from the whole Netherlands, which we have 17 million citizens, will be referred to us. So that's why we also have quite a higher number of TAPS cases in our center. So we performed 3 studies where we looked at spontaneous TAPS, post-laser TAPS, and the treatment. So then we have a couple of results I like to discuss here. So when was spontaneous TAPS diagnosed? It was actually throughout the whole pregnancy. So that's very important to share with you. Keep on looking for TAPS. You can find it throughout the whole pregnancy. And when was post-laser TAPS developed? Well, the main part, so 75%, was diagnosed within 4 weeks after the treatment, but you can see that you can find it even after 17 weeks. So the treatment for TAPS, for the total group, it was 30% expectant, 30% laser, more or less 20% IUT, immediate delivery in 11, and 8% offered selective feticide, and also termination of the whole pregnancy. This is quite a full slide. I just wanted to show you with this slide that with all the centers that were participating, treatment options differ between centers, and that has different reasons. It could be, we offer quite a lot of treatment options, and we also have a very big share of expectant management, and it has to do, like I said before, with that we're in the Netherlands. A lot of patients are referred to us, and that might be the difference why, for example, in London and Houston, they offer much more treatment. And now I'd like to talk about the perinatal mortality. So in the expectant management group, we had 17% mortality, 18% in IUT PET, and 18% in the laser group. The immediate delivery and the selective feticide was 11 versus 7%, and that was a difference, but and then severe neonatal morbidity. Expectant was 30%, 31%, immediate delivery 49%, IUT group was 46%, in the laser 30%, and the selective feticide 25%. So you do see a difference between those groups, and it looks like there's more severe neonatal morbidity in immediate delivery and in IUT PET group. Then I would like to show you the difference in the diagnosis to birth interval. So in the expected management group, it was diagnosed at 22 weeks, and they were delivered at 33. And the immediate delivery group, of course, was very fast. In the IUT PET, it was 4 weeks. And in the laser, we could postpone more or less 9.5 weeks. And the selective feticide, 10.5 weeks. And as you can imagine, there's a difference, a significant difference between the expected management laser feticide compared to immediate delivery and IUT PET. So we didn't see any difference in perinatal mortality. We did see an increase neonatal morbidity in the IUT PET group and in the preterm delivery group. And the pregnancy could be best prolonged in the expected management group, in the laser group, or in the selective reduction group. But how to interpret these outcomes? Because these groups were very much different. They differ in type of TAPS, they differ in spontaneous or in post-laser TAPS, they differ at the moment of diagnosis, and they also differ in the severity. So that's why we're currently performing a trial where we want to look at, where we want to compare the laser treatment with the standard treatment, and we want what we will include them between 20 to 28 weeks. It would be stage 2 or more. And we offer them laser treatment, or well, we will randomize them for laser treatment or the standard treatment. And the standard treatment will include expected management, immediate delivery, IUT PET. And then the primary outcome will be gestational age at birth. And the secondary outcomes will be perinatal mortality, neonatal morbidity, hematologic complications, and procedure-related complications. And we will also perform a neurodevelopmental impairment test at the age of 2. So then I would like to finalize with some take-home messages about the pathogenesis. TAPS is a chronic transfusion through minuscule anastomosis. Antenatal diagnosis will be based on a delta MCA PSV and with additional findings, and it can occur throughout the whole pregnancy. For the postnatal diagnosis, you need hemoglobin, reticulocyte count, and the placenta to check whether there are a small residual or small anastomosis. For the short-term outcome, you have a high mortality, and mainly in the donor, and there's prematurity. And for the long-term outcome, there's a high risk for donors, especially in the spontaneous TAPS cases. They are at risk for bilateral deafness and cognitive delay. And for the antenatal treatment, we still don't know what the best treatment option is, and currently we have an RCT running. So thank you very much, and I also would like to give a special thanks to Lisanna Tollenaar. She just recently finished her PhD, and she helped me with all these illustrations, and she performed lots of these studies as well.
Great. Well, thank you so much, Femke. That was brilliant. Really nice overview of the research that's been published so far, and also highlighting some of the challenges in the different diagnostic criteria and the definitions and so on. There are already lots of questions for you, so I'm gonna take some of them, and then we move to Veronica's talk next. I guess one of them, very quick question, can monoamniotic twins have TAPS? So have you ever seen TAPS in monoamniotic twin pregnancy?
I never have seen one, and the reason why is TAPS is caused by tiny anastomosis. And if you look at monoamniotic twins, what's very typical, if you look at all the placentas of monoamniotic twins, they share the placenta and they always have their umbilical cords very close to each other. And they almost always have a big AA. And because they have those big anastomosis, it's not, I think that's one of the reasons why they don't develop TAPS. And that's why we didn't see it.
Yes, and so I agree with you. And in fact, similarly to twin-to-twin transfusion syndrome or TTTS, which is less common in monoamniotic twin than diamniotic twin, again, selective fetal constriction is less common in monoamniotic twins. And TAPS, again, if you look at the cases recorded in the literature, and certainly Veronica can comment on that, the majority of them are diamniotic, very rarely it is monoamniotic. I'm aware of maybe one case report that was in monoamniotic twin pregnancy, but I agree it's very rare. Another question, FMK, how about the instance of reverse TAPS? So A is initially donor and then changed to be the recipient.
Yeah, and then probably you mean in TTTS being a TTTS a donor and then coming to a TTS or TAPS recipient. In the beginning, we thought that the TTS recipients were more at risk to become the TAPS donors. We did previous studies in our own cohort, and then we thought that it was more often that TTS recipients became the donors. But we looked at this in this big international cohort, and we didn't see that anymore. So I think they both are at risk. One of the reasons, or one of the ideas that we thought that TAPS recipients were more at risk to become a TAPS donor had to do with the pressure difference being a TTS recipient, that they were more receiving, there might be less pressure, reducing the pressure of the polyhydramnios, that there might be more transfusion from the recipient, TTS recipient towards the TTS donor. So that's why it would turn. But actually, we don't see that anymore in the current study. So I think it's based in which residual anastomosis you have. So TAPS is based in if you only have one tiny anastomosis, residual anastomosis left from the recipient to the donor, or the other way around. That's what's causing TAPS. Does that answer your question?
That was a question from Chen Min. So I guess what you're saying is that in the past, sometimes you see the recipient becoming the donor or becoming the anemic twin.
Yes.
And the ex-donor becoming the polycythemic twin. I think that's what I think he meant.
Yeah.
And on the same note, so just TTTS and TAPS. So some cases that actually present for the first time. So some present with TTTS, and you would find the same criteria of TAPS. What's your experience with these cases when you have TTTS but also have the diagnostic criteria of TAPS?
Yeah, and there's also quite some research on that too, because what we see, and that's I think what we saw also before, you do see in TTS cases, you do see in 10%, you also see anemia and polycythemia, and that of course has to do with a large transfusion from the TTS donor to the TTS recipient. So there can also be anemia and polycythemia. So some of them call that TTS and TAPS, some of them call that TTS with anemia and polycythemia. If you look at the pathophysiology of TAPS, and like I presented today, that's through tiny anastomosis. And if you have TTS with also anemia and polycythemia, that's transfusion through large anastomosis. But of course, there can be a combination. And what I often draw to patients is like the three circles, the SAUGR, TTS, and TAPS, and sometimes they overlap. And it's the same that you can have an SAUGR, which is based on the placenta share. So you have one twin has a smaller share, the other twin has a bigger share. But the transfusion, so the TTS, is caused by transfusion through the anastomosis on top, so at the surface. And I think that's more or less the same. But the pathophysiology is different because there are larger anastomosis if you have TTS also with anemia and polycythemia.
Okay, great. So I agree with you. And in fact, when we looked at our cases, the prognosis of these cases tend to be quite good because often when you do the laser to treat the TTS, it also treats the TAPS. So actually, to some extent, the numbers are small, but when we looked at the small numbers, the prognosis was actually almost the same as TTS.
Yes, I agree. And I think it has to do with TTS occurs quite fast through large anastomosis. And I think, but we still need to do much more research on TAPS. But I think what's the problem with TAPS, and might be a problem with the TAPS donors, is they are chronic anemic, and they are some of them have it very early in the pregnancy. We didn't pick it up yet, and they are for a long period anemic, and that might be one of the reasons why they have impaired long-term outcome. In the difference to being anemic polycythemic during TTS, then you're for a short period anemic, you stop the transfusion with the laser, and then you can recover as a twin.
Okay, there are many questions, and I think we maybe I'll take, let's say, maybe 2 more questions, and then we'll move on to the rest of the speakers, and then we'll go back to this very interesting questions, very interactive. So Sandra Benson, she's asking, can monozygotic, dichorionic, diamniotic twin pregnancies have TAPS?
We reported one. We always say it has to do with being a monochorionic twin, but there are some cases reported that dichorionic placentas, there are somewhere tiny vessels connecting. And if you have a tiny vessel connecting and you have a transfusion from one twin to the other, then you can develop TAPS. It's very, very rare, but never say never.
Okay, that's great. I agree with you. And last question or last point or comment before we move on to the other speakers, and then we'll come back to this long list of questions that I have. So what's your what will you say to people who would say, well, I don't think we should monitor routinely for TAPS in uncomplicated monochorionic twin pregnancies because we don't really have good evidence on the natural history. And so far, we don't really have any effective intervention or sort of evidence to say how to manage them.
Yeah, thank you for that question. It's a very interesting question, of course. Yes, we still don't know what the exact or the best treatment option is antenatally. I think we should need to look for it. But with the studies and the research that I just showed you, you can see those twins are really at risk. And sometimes there's the belief in obstetricians or fetal medicine doctors, I don't think in fetal medicine doctors in general, but there's a belief that this might be like the smaller brother or sister of TTS. And as we showed in these long-term and short-term outcomes, these twins are at risk. And if you have an increased risk of becoming bilateral deaf, that's a very severe complication for those twins. And we really need to keep on looking for this, and to also, even if at that stage we might not be able to treat them yet, it's very important that we screen for it. If we can find those children and find that they are bilateral deaf, and we can find that after birth, we can help those children. We can give them hearing aids. We can help them to give them better outcome. So yes, we definitely need to look and screen for TAPS in uncomplicated monochorionic twins.
So this is really interesting, and it's a big debate. I don't know, maybe it's not in the Netherlands, but certainly in the UK. So I think I'm sure we'll come back to it later, and just maybe sort of discuss with you some of the challenges or some of the different views about routine monitoring of the MCA peak study velocity and uncomplicated monochorionic twin pregnancies. But thank you so much, Femke. That was fantastic, brilliant, beautiful slides, and nice, clear messages. But we still have lots of questions, so please stay with us because I think the discussion will have more even interesting discussion later. So thank you. So as I mentioned, Veronica Georgion, who is one of our fellows, who has completed a meta-analysis on the perinatal outcomes of pregnancies complicated by TAPS, and she's just going to sort of share with us some of the key outcomes.
Hi everyone. Thank you, Asma, for the introduction. It's a great honor to be here to present the results of our systematic review and meta-analysis on the perinatal outcomes of pregnancies complicated by TAPS. Our research group conducted a systematic review of the literature that has been published until July 2020. After screening 254 articles, we selected 40 studies after excluding studies on triplets, on dichorionic twins, on cases where TAPS and TTTS were coexistent, and also cases where with overlapping data. To do that, we excluded articles where the presence of overlapping data was disclosed, but also we excluded all cases from the same centers that were included in the TAPS registry, that is the largest study published so far. 38 studies were used in the first analysis on spontaneous versus post-laser TAPS, and 21 studies were used in the second analysis according to the different management options adopted. In both cases, a random effect meta-analysis of proportions was used to analyze the data. We included cases of MCDA without fetal anomaly with a prenatal or postnatal diagnosis of TAPS. Our primary outcome was mortality that we define as intrauterine death, neonatal death within 28 days of life, and perinatal death, defined as IUD and neonatal death. The secondary outcomes were morbidity and preterm birth. In terms of morbidity, we analyzed the severe neonatal morbidity, including at least one of the following complications, such as RDS requiring treatment, PDA required treatment, NEC more than stage 2, ROP more than stage 3, ischemic limb lesion, and severe neonatal morbidity, severe neurological morbidity that we define as the presence of neurological lesions associated with adverse outcome. In terms of preterm birth, we also perform a sub-analysis considering spontaneous and iatrogenic preterm birth. All these outcomes were stratified according to the type of TAPS, spontaneous TAPS and post-laser TAPS, and according to the management options that was adopted in pregnancy. In TAPS diagnosed in pregnancy, so only prenatally TAPS. Let's start with the analysis including the spontaneous and post-laser TAPS. Intrauterine death occurred in 5% of twins complicated by spontaneous TAPS and 10% of twins after a treatment with the laser because of TTTS, so post-laser TAPS. And similar figures for neonatal death were 4% for spontaneous TAPS and 9% for post-laser TAPS. The rate of double loss was 4% in spontaneous TAPS and 8% in post-laser TAPS. And for both outcomes, we can see that there isn't an overlap of the confidence intervals. Therefore, we can say that there is a substantial differences between the two groups in terms of mortality. Very similar results were obtained considering the live birth rate. In spontaneous TAPS, live birth rate was 90%, with the survival of at least one twin 52% and the survival of both twins of 49%. In the post-laser, the survival rate was 83.7%, with 45% the survival of at least one twin, and the survival of both twins was 37%. That is related to the higher risk of double loss. In terms of morbidity, severe neonatal morbidity occurred in 29% of cases after spontaneous TAPS and in 33% of cases in post-laser TAPS. Interestingly, the severe neurological morbidity affected 4% of twins complicated by spontaneous TAPS and 11% of twins after the overall rate of preterm birth was 86% in spontaneous TAPS, with 59 delivered within 34 weeks and 30% delivered within 32 weeks. On the other hand, all cases of post-laser TAPS delivered preterm with the lower gestational age at birth, as we can see here. 79% delivered before 34%, 59% before 32%, and 22% before 28%. Let's move on the analysis about the different options in pregnancy. As we can see, there wasn't a big difference in terms of mortality among the different groups. So indeed, the perinatal death rate in expectant management was 16%. In the laser group was 17%, and in intrauterine transfusion group 50%, and in selective reduction group about 12%. And the double loss was 4% in after expectant management, and no cases of double loss were recorded after laser group, in the laser group, and after intrauterine transfusion. Also, the live birth rate was very similar in the expectant, laser, and intrauterine transfusion group. So no difference we can see in terms of the survival of at least one twin and in the survival of both twins. The severe neonatal morbidity affect 27% twins that were managed expectantly, 29% of twins in the laser group, 38% in the intrauterine transfusion group, and 23% in the selective reduction group. Regarding the severe neurological morbidity, the lowest rate was registered in the laser group with 4%, but against the 8% and 10% in the expectant management group and intrauterine transfusion group. However, we cannot draw conclusion because there is an important overlap of the confidence interval here. The overall rate of preterm birth was very high in both groups. What we can see is that the spontaneous preterm birth was higher in the laser group compared to the expectant and intrauterine transfusion group. This is the largest meta-analysis to date and on the perinatal outcome of TAPS according to the type of the disease and the management options. Nevertheless, the small size of studies, the retrospective design of this study, and the important heterogeneity in management are the main limitation of this meta-analysis. Indeed, we were not able to conduct a sub-analysis in each management group according to the type of TAPS. However, these findings suggest that the risk of perinatal mortality and severe neurological morbidity are relatively higher in pregnancy complicated by post-laser TAPS compared to spontaneous TAPS. although a real comparison between the two groups was not possible because of the design of the study included in the systematic review. On the other hand, the small numbers of included study regarding the management didn't allow us to extrapolate evidence about the optimal management when facing TAPS. Therefore, further randomized trial and powered study are necessary in order to evaluate the impact of the different management on the perinatal outcome of twins complicated by TAPS. Thank you.
Great, thank you so much. So really, the key messages is that it seems that the outcomes of post-laser TAPS is worse than spontaneous TAPS. And certainly it'll be good maybe in the discussion that we will also hear the views from Femke and from also the people on the webinar. The fact why post-laser TAPS is worse than spontaneous TAPS, and it might be just the fact that also you have the TTTS. So this pregnancy is also complicated by TTTS. And then you've got the TAPS. So that might be a confounding variable why the one that have post-laser TAPS do worse than spontaneous TAPS. And you're absolutely right. The fact that because the data is observational and biased and there's no randomized control trials, the data does not tell us what is the best treatment option in TAPS. Should we do expectant management? Should we do laser? Should we do transfusion? Should we do selective reduction? But it's also not straightforward because it has to take into account the gestational age, the severity, technical variables, and so on. But that would be a really good discussion. So, and I'm sure we'll have lots of questions for you, Veronica, as well. So thank you so much. That was very clear. I'm going to move on to Laura, just because I'm conscious of the time. And Laura, would you mind if you present your case? And it's a case that we here looked after at St. George's where I work.
Thank you very much, Asma, for the introduction and for inviting me to present this clinical case. So I'm going to talk to you about a case of TAPS that we saw this year at St. George's. So our patient is Gravida 2 Para 0. She is 33 years old. It's a pregnancy that was obtained after IVF, and she's pregnant with monochorionic diamniotic twins. She has no medical history. She is not a smoker. She doesn't take any alcohol or drugs, and she has a normal BMI and is rhesus positive. She is initially referred to St. George's for a suspicion of twin-to-twin transfusion syndrome. On the first scan at George's, she is 20 weeks and 2 days. The first twin has an estimated fetal weight of about 260 grams and presents with anhydramnios. There is also an abnormal flow in the umbilical artery for this twin. The second twin has an estimated fetal weight of about 290 grams and presents with polyhydramnios. And this twin also has a high resistance in both the umbilical artery and ductus venosus. And so after this first scan, we can conclude yes, that it's an NCDA twin pregnancy with a small weight discordance of about 10% between the twins. But the first twin has biometries below the 10th centile. We could confirm that there was an acute twin-to-twin transfusion syndrome that is a stage 3 according to the Quintero classification, since though the first twin had oligohydramnios and an absent end-diastolic flow in the umbilical artery, whereas the second twin presented with polyhydramnios and an increased resistance in the ductus venosus. On the scan, the cervix was long and closed, about 4.5 centimeters. So on these two pictures, you can see to the left the first twin, so the donor that is completely stuck to one side of the room and that has an empty bladder. And to the right side of the screen, you can see the recipient that has polyhydramnios with deepest vertical pocket of fluid that is about 12 centimeters. These two pictures show the abnormal Dopplers. So to the left, again, the first twin, the donor, that has an absent and diastolic flow in the umbilical artery. And to the right, the recipient that shows a high resistance in a high pulsatility index in the ductus venosus. So after discussion and counseling with the patient, we offered the laser surgery to treat the PTTS syndrome, and so the patient agreed to undergo the surgery. And I'm going to show you a short video of the procedure. So we are entering in the amniotic sac of the recipient, and you can see the recipient baby here. This is the cord insertion of the recipient, and here you can see the folding of the membrane and the cord insertion of the donor twin. So we are going to identify the vascular equator of the placenta, and you can see here one anastomosis between the two circulations. To the left side, we have the blood vessels coming from the donor twin, and to the right side of the placenta, we have the blood vessels coming from the recipient twin. And here you can see the laser fiber, so that is burning these anastomoses between the two circulations. And so we are burning these two first anastomoses, and then we continue to go down along the vascular equator, and we follow here the donor blood vessel that's anastomosing with the recipient, and so these anastomoses are selectively coagulated. So we didn't perform the Salomon technique. We are so coagulating the anastomosis selectively. And that's here, again, one anastomosis that is coagulated. And then we continue to go down along the vascular equator until the edge of the placenta. And yeah, finishing to coagulate this anastomosis. And then here, going down along the vascular equator, these vessels then do an anastomosis, and then we get to the uterus. And here you can see the recipient twin to the right side. And here is the donor, the feet of the donor twin that is completely stuck to the side of the womb. And you're going to see here that this twin is really wrapped in the membrane. And that's the donor twin. So all the patients that have a laser surgery at George's have a scan the day after the procedure. And on this scan, we found normal Dopplers for the ex-donor, but the ex-recipient had presented absent end diastolic flow in both the umbilical artery and the ductus venosus the day after the surgery. And you can see it on these pictures. So to the left, the absent end diastolic flow in the umbilical artery, and to the right, the absent end diastolic flow in the ductus venosus for the ex-recipient. We always ask the patients to have organize a follow-up scan 1 week after the surgery, either locally or at George's. And in this case, we ask the patient to come back the week after because of these abnormal Dopplers in the recipient. And on the follow-up scan, 1 week after the surgery, the recipient, the first twin, so the ex-donor, showed oligohydramnios. So there had been some reaccumulation of amniotic fluid, but there was an absent end diastolic flow in the umbilical artery and an abnormal peak systolic velocity in the middle cerebral artery. On the other hand, the ex-recipient had normal amniotic fluid, so there had not been any recurrence of the polyhydramnios, but this twin also presented with an abnormal peak systolic velocity in the middle cerebral artery. So after this follow-up scan, 1 week after the surgery, we diagnosed a post-laser TAPS with the twin one, the first baby, the ex-donor having MCA-PSV above 1.5 mums, and the second twin, the ex-recipient, presenting with a MCA-PSV below 1 mum. The first twin also had mild ascites and pleural effusion, so it was a stage 4 TAPS. And on the second twin, we could also see the sterisky appearance of the liver. So on this picture, you see the MCA peak systolic velocity that was about 46 centimeters per second for the first twin, so above the reference range. And this velocity that was about 20 centimeters per second, so below the reference range for the second twin, the ex-recipient. On this video, you can see that the first twin, the ex-donor, showed some pleural effusion and also a mild rim of ascites 1 week after the laser surgery for TTTS. And on this video, you can see on the ex-recipient the sterisky appearance of the liver with these bright echogenic spots in the liver. So the patient was counseled again about the possible management for the TAPS, and because of the early gestational age of 22 weeks and also the severity of the TAPS, that was a stage 4, we offered a repeat laser surgery, and the patient agreed to undergo the intervention. And I'm also going to show you a short video. So here you can see the ex-recipient that has very bright red-colored skin. And so that's the polycythemic twin. And going to the left, you can see here the ex-donor that has a very pale white-colored skin. And so we looked again at the vascular equator, and we found some remaining anastomosis that were once again coagulated with the laser fiber. The patient came back the week after the surgery. The first twin showed a resolution of the eye drops, so there was no more ascites and pleural effusion, but the peak systolic velocity remained high in the middle cerebral artery. The second twin, the ex-recipient, still had a low peak systolic velocity in the middle cerebral artery. But we know that these findings can take some time to go back to normal. And so we arranged for a weekly follow-up scans between the local hospital and George's. And the patient came back 3 times at George's at 23, 24, and 29 weeks. And on this slide, you can see the evolution of the MCA-PSV for the first twin, so the ex-donor. And after the repeat laser, you can see that the peak systolic velocity came back to normal 1 week after the surgery and remained normal. For the second twin, the ex-recipient, the peak systolic velocity took some more time to come back to normal, but eventually also came back to normal. Every pregnant woman that had a laser surgery is offered a brain MRI, and our patient agreed to do this MRI that was done at 31 week, and that showed a normal brain for both twins. and she had an elective cesarean section at her local hospital at 34 weeks. The first twin was born and with a weight of about 2 kgs. The second twin was about 2.3 kgs. And you can see here pictures of the two babies with normal skin color. And both babies are doing well at this stage. So, yes, thank you very much for your attention.
Thank you so much, Laura. I'm sure lots of questions, I can see that, but thank you. It's an interesting case. And you can see that actually when you go back with the laser the second time, there was anastomosis that were not photocoagulated. But once you do that, I think it's, the outcome is good. But it's interesting that the post-laser taps presented very quickly, literally like a week or 10 days after that, and presented with stage 4 already. So already one of the twins have hydrops, had pleural effusion, had ascites, and certainly we've seen few cases where you have the post-laser taps. It does present early, most of the times within a few weeks, and if it doesn't present, sort of in our experience, does not. Maybe just we had one case where it presented about 32 weeks, where by that time we give steroids and deliver. So I think if it presents after the laser, it's often in the first few weeks. And if it doesn't, I guess you managed to get all the anastomosis, you haven't missed anything, or none of them have recanalized. But, good outcome so far. Fine, we'll go back to have some of the questions and discussion. So Enrico Lopriori, who's neonatologist, is a professor of neonatology from Leiden, who's also joined us, and he's also another expert in TAPS. In fact, he's the one who described TAPS in the first place. So thank you, Enrico, for joining. And he did ask, so why do you term this acute TTS? I would say that TTS is good enough. So Laura, I think she did mention it's acute. I mean, yes, you're right. It's not an acute TTS. But certainly that was the diagnosis that was the patient given, because I think she was followed up closely and the fluid was completely normal. And in that, on the scan before the referral, there was a oligohydramnios, polyhydramnios sequence, and you see the discordance in the size was only 10%, as Laura mentioned. And therefore, probably that would be the explanation why she was given the diagnosis of acute TTS. But we don't usually use chronic or acute TTS in our sort of diagnosis. I think only maybe acute TTS if everything is fine and third trimester late, suddenly there is oligohydramnios, polyhydramnios. That's when I would use acute TTS as a term. So Jose saying that anastomosis remained was not so small. Yes, you're right. I think that there was some anastomosis that was missed, and you can see that in the second or repeat laser. Shunay, this question, are there any features to look at to predict intracranial abnormalities in both laser taps? Do you routinely do MRI in TAPS cases? Very interesting question. I'll tell you what we do at St. George's, and I think Laura have already alluded that. So for the last maybe 5 or 6 years, all cases that have TTS or laser for TTS, we do offer brain MRI at about 28 to 30 weeks. Not all women opt for it. Not all women go for it because, in view of the advanced gestation, and if the woman is committed to the pregnancy, some women say, well, what's the point of having it? It's not going to change anything. I'm going to have the babies regardless. But we do offer it. In TAPS, we do offer it. It'll be interesting to hear, Femke, what do you do in the Netherlands, in Leiden? Do you do MRIs for all cases of TAPS?
Thank you. Yeah, I'm sorry for my name. That's the name of my husband.
Yeah.
Because he has a cable connection to the internet. Very interesting presentations, the two you showed. Thank you very much for that. Could you just, I was looking at the other questions and I was very happy to ask and answer another one about the Solomon technique, but could you repeat the question one more time, please?
About MRI, do you do, in all cases of TAPS in Leiden, do you do MRIs?
We don't do structural MRIs, also not in our treated TTS patients. It just has to do with oh, well, like you said, we're not going to change anyway. And it also has to do with laws in the Netherlands. After 24 weeks, we're not allowed to terminate pregnancies anymore. So it will not influence our treatment prenatally. But what we do after birth, we all our treated patients get a cerebral ultrasound. So we do ultrasound after birth, but we don't, and if it's abnormal and we think there's a reason to do a neonatal MRI, we will perform an MRI. And I'm really happy that our colleague and Professor Lopeyor joined. And as I can see in the background, he's on call today, and he will comment on that as well, that what we do, if we do see abnormalities afterwards, we will do a fetal neonatal MRI, but we don't do structural prenatal MRIs in our treated patients. Unless we do see something on the ultrasound, we see abnormalities, so we do screen, so we do look at the brains of the fetuses, and if we do see an abnormality, then we will also counsel patients together with a pediatric neurologist, and if we think it's indicated, then we'll do a fetal MRI, but not structurally.
If I may comment, Asma.
Yes, and I unmuted you, Enrico, particularly for this.
I totally agree, but it depends, of course, on your own center. If you have good cranial ultrasound radiologists or neonatologists, then you can rely on your ultrasound, on your cranial ultrasound postpartum in the neonatal ward. But if you doubt your ultrasound, then maybe it's a good idea to do an MRI. In our center, the people doing the ultrasound are quite experienced, so we only do the MRI, as Femke said, in case of doubt. But it may change from center to center.
But that's mainly postnatally, Enrico, is it not antenatal?
Yes, sorry. Yes, postnatally.
Yeah. So I think it's a very valid point. Is it? If you work in a country where termination is not a legal option after 24 weeks, in this case, what's the point of doing antenatal or fetal brain MRI in these cases? I mean, in the UK, the law is different, and therefore we do offer it. I would say majority of women, at least maybe 60-70% of them will actually agree, but some would say, no, I don't want it. Fine, perfect. Well, thank you so much. Enrico, you did mention a comment which is really useful, and I think it's good to bring it up to the discussion. You said you only use the term acute TTS for rapid inter-twin transfusion within minutes or hours. For example, in acute peripartum TTS or acute perimortem TTS. Interesting, because I think a lot of people, certainly in the UK, I come across cases where clinicians will give the diagnosis of acute TTS if the pregnancy has been monitored, things were fine, and then suddenly there is oligohydramnios, polygohydramnios sequence, particularly if there is no large size discordance between the babies. So you don't agree with that?
I think he's unmuted.
You need to unmute yourself. Okay, let me actually unmute you. Here we are. Yeah, here we are.
Yeah, I was not allowed to unmute myself. Now, I think it's important to agree on the same terminology. Otherwise, we're gonna use the same term for different disorders. You're right. This TTS, usually the classic case, like the one you presented, occurs quite quickly within a few days, and you could term this acute. But then, how would you call the inter-twin transfusions where it's within minutes or hours? We usually use the word acute for those cases, and when it's within the delivery or when one of the two dies. But all the other, the classic forms, we just use the word TTS, but I think we can decide otherwise as long as we use the same word. Otherwise, we are going to talk a different language.
Yes, absolutely. I agree with you. So it's another very interesting question. It's related to the case. So if you have a TAPS after laser, post-laser TAPS, when would you consider repeat laser or transfusion? So in this case, the TAPS was happened a week, 10 days after the laser, and therefore we decided to repeat the laser, and that was effective and sorted out the problem. When do you consider intrauterine transfusion?
Are you asking me, Asma?
I'm asking.
Femke can answer this question.
Femke.
I'm happy to answer. Or did you want
Luckily,
somebody else?
Enrico does not. I mean, he only sees the babies when they're out. He luckily does not have to make this decision.
Oh.
So Femke, yes. Are you?
I'm sorry, your screen free.
I can see you clearly. So go ahead, Femke.
So regarding what kind of treatment you should do, and we still don't know yet, and that's why we're going to perform. Do you still see me? Yeah. Yes, that's why we're going to perform the RCT to see how we should treat these patients. But I can imagine in this case that because it's still quite early, 22 weeks you have TAPS, and with the research till this far, which we performed, is that you can prolong pregnancy longer if you have a successful laser compared to repeated intrauterine transfusions. Because if you do intrauterine transfusions, what we studied before is we see that, well, on average, we need to repeat it after 2 weeks. So that means that you need to do that repeatedly. And it can also be that after a couple of days, you have anemia and polycythemia again. So in this case, I can imagine, because I assumed it was a posterior placenta, assuming on the images of the fetoscopy, it looked like not such a hard fetoscopy. So I can imagine if you have easy access to go back in, and then you can treat the cause and then can prolong pregnancy. As you showed in this specific case, you prolong to 34 weeks, and I think you prolong to 34 because of you deliver all complicated monochorionic twins at 34 weeks. That's correct, Asma?
Yes. Yes, we followed the ISWAG guideline, and when we wrote it, we didn't. I mean, the evidence is not there. There's no evidence to say when is the ideal time to deliver twin-to-twin transfusion syndrome treated by laser. There was some observational data from the French group where they suggested that there is still some residual risk, and therefore, so then in our practice, we tend to deliver after 34 weeks after a course of steroids. But I appreciate that there is different practice. Some people, if it's completely uncomplicated, they'll carry on until 36 weeks. I know that even sort of in Belgium, and I guess in the Netherlands as well, you even do vaginal delivery at 36 weeks.
Yes, we do. Yeah.
But we're a bit more conservative, I think.
Yeah. Oh, but maybe a bit later on, Enrico can comment on this as well, because I think it's also thanks to the neonatologist that he pushes us to keep the patients as long as pregnant as possible. And I'm really happy for that, because all those studies that we do show that gestational age is the most important risk factor for neurodevelopmental impairment. So that's why I think it's very important that we try to prolong those pregnancies. I'm not really sure whether you want me already to answer a little bit on the question about the Solomon technique in this case.
I mean, there are lots of questions earlier that we have not answered. So I think we're going to go through and try to answer as many as possible. Just maybe because not everybody can see the questions in the chat box or looking at it. It's an interesting question from Gorbit Banda. What's the instance of acute intrapartum TTTS in uncomplicated monochorionic diamniotic twin pregnancy? And Enrico already have responded, and he said, I think it's very rare, only 1%, but good data is lacking. And you're absolutely right, good data is lacking, because the main reason, at least in the UK, where we often, or traditionally have advocated cesarean section for monochorionic diametic twin pregnancy, apart from the fact that it's easier and I guess it's less risky, and therefore us as obstetrician would say, okay, well, that's a safe option. Is a fact because of the risk of acute intrapartum TTTS. However, and on one time I said, well, how common is this? And I tried to look at the literature, and Enrico, there's no good studies, because how do you actually diagnose acute intrapartum TTTS?
I think
we're not scanning them, we're just doing a CTG. And if the babies are born in a good condition, in the UK at least, we don't routinely measure the hemoglobin. If the baby's born in good condition, it will not go to the neonatal unit and will not have any investigation.
I think that there is a lack of good definition for acute TTTS. I think the most important thing is that we first must exclude that it was not a TAPS case, because I think that TAPS is much more common than acute peripartum TTS. And I think that most cases that were reported in the literature in the past as being an acute peripartum TTS were actually misdiagnosed TAPS cases. So if you would look more carefully and inject the placenta with color dye or measure the reticulocyte count, you would see that it's a TAPS case. Unfortunately, most people do not inject the placenta, so you would not be able to see the characteristic aspects of a TAPS placenta, and most people forget to measure the reticulocyte count. But if you would do that, probably you would see that in most cases, when there is a white and a red baby at birth, it's most probably a TAPS case, but it can be an acute peripartum, but you first have to exclude it's not a TAPS. An acute TTS, we would define it as a white and red baby with a large difference in hemoglobin at birth of more than 8 grams, and with equal reticulocyte count and with a placenta which looks like a normal monochorionic, so with large anastomosis with an AA, which allows acute blood from going from one side to the other. In TAPS placenta, you only have very tiny anastomosis, so as Penke probably said, there is no way you can have an acute blood transfusion from one baby to the other.
Yeah, great, fantastic. Thank you so much. There's one question from Kautar. Which curve do you refer to compare the MCA Doppler? And I think I'm picking up this question because I think it's really important. It's quite a practical question. So for people who are doing ultrasound scans or the fetal medicine specialist, obviously diagnostic criteria itself relies on MCA unless you're stage 3 or higher, and therefore you have evidence of fetal compromise. The question, which MCA Doppler reference chart, I guess, curve do you use? So Femke, do you want to comment on that? Or maybe I can tell you meanwhile, are you mute? Okay, are you muted? So sorry. And I'll tell you why I'm doing this. Okay, fine. You are unmuted now. And meanwhile, I was saying, well, the one that we use is, so we use, let's say, the Viewpoint ultrasound database, and there's already a chart. So we use the peak systolic velocity and a reference range for that. If you don't have that, or if you don't use the Viewpoint, there are websites like perinatology where there is MCA peak systolic velocity MOMS chart. You put the gestational age and you put the value, and would give you the actual MOMS to be able to say it was above 1.5 or less than 1 or 0.8 MOM, and also for you to calculate the discordance. Femke, what do you use in the Netherlands?
Oh, we don't have a specific twin chart, so we use the Mari chart just as we use in singletons, and in the system that we use Higgs. We do get the MOMS reported, but we do use the Mari chart, which is the chart that we use in singletons. And for research, and as we also mentioned in research projects, we often use a chart made by Clarice et al. He performed that in Belgium, in Leuven. There's also a very well-known center for twin complications, and he made a chart for monochorionic twins. And that's what we use in research. but daily practice, we use the MARI chart.
Lovely. Again, another question from Tunay. Have you noticed significant changes in cardiac reserve in terms of contractility, so TAPSE and MAPSE measurements in both laser TAPS cases? Is this what predisposes these babies to have worse perinatal morbidity? So there's loads of questions from people about what is the explanation of the impaired neurodevelopmental outcome, particularly you mentioned about the deafness. Yeah. What's the explanation in cases of TAPS? And I guess Tunay is saying that is it actually difference in contractility of the heart that leads to difference or worse perinatal morbidity?
What we do think is one of the reasons why those babies are more at risk is what we see in those in the donors, that they are more hypoxic. If you look at them after birth, you see lower pH level in donors compared to recipients. If we look at albumin levels in donors, we see the albumin level is lower. If you look in detail at those placentas of the TAPS cases, what you do see is that also they're tiny anastomosis, but what you see, what's typical is that the vascularization on the placenta is also reduced compared to the recipient. So what we think, what the cause might be of the neurodevelopmental impairment, and especially the bilateral deafness, is being for long-term anemic and maybe also hypoxic. And so it doesn't have to do with the contractility of the heart. And we don't see really signs of cardiac compromise in those twins. Of course, if it's severe anemia, you do see high drops and you do see reduced contractility, but not in all cases. And also, if you look at those cases that were bilateral deaf, there are also cases included with only stage 1 or 2. So even you can have brain damage or deafness, even if you didn't have a stage 3 or stage 4.
Yeah, so and therefore the staging is not necessarily prognostic of the risk of neurodevelopmental disability, which is the same case as TTS in terms of quantero.
But and that's the big difference with TTS and TAPS is that TTS we're much more familiar with for quite some years, and we did quite some studies. And I think the big difference in TTS and TAPS is TTS comes quite fast. You treat it, and then those babies can recover in utero. And the difference with TAPS is there are also a lot of cases that are exposed to chronic anemia and polycythemia for quite a long period. And that might cause those severe complications like neonatal morbidity, mortality, and also the neurodevelopmental impairment. And that's not what we stress today and what we explain today. But if we talk to those parents afterwards, most of the parents, they are more concerned about their TAPS donor than their TAPS recipients. Also in like mild development or mild behavioral problems. So I do think that it's very important to screen for TAPS and also in uncomplicated monochorionic twins. Because that might be one of the reasons if you think, well, if we find a severe case, we see high drops, so then we will find TAPS anyway. We don't need to do the MCA-PSVs. But as we showed in previous studies, also stage 1 or stage 2, you can have severe problems afterwards. So, and then you only find the stage 1 or stage 2 if you do repeated MCA measurements. And we advise to do it at least bi-weekly, so every 2 weeks. And we started, depending, of course, on whether you're a specialized center or not, but at least started 16 weeks. But in our center in Leiden, we already started 14 weeks.
Okay, fine. Well, I think that brings us to the point that we did touch on it briefly before Veronica's talk about whether we should routinely monitor for the diagnosis or development of TAPS in all uncomplicated monochorionic twin pregnancy. And there's different recommendation and different guidelines. So the ISWA guideline, the International Society of Ultrasound Obstetrics and Gynecology, we did actually recommend that we should routinely monitor for MCA peak systolic velocity. And I think there's a question asking from when. I think certainly from 20 weeks, but we often start from 16 weeks. In NICE guidelines, so in the UK, we follow NICE guideline, and the NICE guideline was updated last year in September 2019, and we had a long discussion about that. And this is where this problem of, we don't know, we're not sure about the natural history, we don't know how to manage them. Sometimes you see taps, the MCA peak systolic velocity is high, and the next scan it goes back to normal, and we don't know what's the best management. So this is some of the, not necessarily the criticism, but the challenges that some of the clinicians have brought up, certainly in the UK. They say, well, why should we monitor? We don't know how to manage. And therefore, NICE guideline, their recommendation is the fact that we should monitor for TAPS from as early as 16 weeks, but only in the complicated ones. So the post-laser, laser for TTS, post-TTS, so they have TTS had laser and then the follow-up, or the one that have polyhydramnias, or the one that have selective fetal growth restriction, or have abnormal Dopplers or cardiac cardiomegaly and so on. So there's something. They did not recommend to monitor uncomplicated monochorionic twins in view of the lack of evidence. But we heard earlier from Femke saying, but this is a potentially dangerous condition, and it's associated with perinatal mortality and morbidity and long-term neurodevelopmental problems, and therefore we should be looking. My personal view, the lack of evidence does not necessarily mean we should not look for it. Because the numbers of monochorionic twin pregnancies are small. The number of TAPS will be even smaller. And we're trying to figure out how to manage these cases. So I think the fact that I don't think it's right to say, well, let's wait until we have good quality evidence before we actually recommend monitoring or looking for it. Because during these years, there will be lots of babies dying or being harmed by this condition. And I guess it's our responsibility that we should look for it and do the research to try to figure out what's the best management. I don't know, do you agree with me that all of the speakers on the webinar agree, or do you have different opinion?
Of course, I agree that I already said that to you, but maybe someone else wants to comment first.
I mean, maybe we hear Laura, because Laura, you work in Belgium, and Veronica, you work initially in Italy. So what do you do? I'm sure Enrico would agree, of course, that we should monitor for it. No question. Can you unmute yourself?
Yes.
Okay.
Well, I would measure the MCA-PSV on every follow-up scan. So I guess we would do it. We would look for it for every monochorionic twins.
So in Belgium, they do. Veronica, in Italy?
Yes, in monochorionic twins, we usually measure the Doppler always from 16 weeks.
So we always measure the MCA peak systolic velocity. Fantastic. But certainly, I think, as I said, in the UK and in the US as well, if you look at their guidelines, do not recommend routine monitoring. Whether you agree or not, that's another story. I'm just going to move on because there's lots of questions about delayed cord clamping in monochorionic twin pregnancy. And I know the team in the Netherlands, so Enrico and Femke's group, have published a number of studies on delayed cord clamping in monochorionic twin pregnancies. What's your recommendation? What do you think?
Enrico, would you like to comment on that?
That's a $1 million question. And actually, it's a big problem because nowadays everybody is very enthusiastic about delaying cord clamping. We see from a neonatologist point of view, we have the impression that if you do that instead of doing early cord clamping, that it's better for the transition, it's better for the baby to stabilize and to adapt to the the extrauterine environment. However, in monochorionic twins, it's more complicated because they are connected with each other if they have not been lasered yet. So I think that in cases, monochorionic twins that have been lasered, you can just do the same thing that you do in dichorionic twins. They will not, and I would advise to do the delayed cord clamping. And there are nowadays all kinds of special resuscitation tables that you can go very near to the mother and do your thing as a neonatologist near to the mother. In an uncomplicated monochorionic twins, or in all monochorionic twins that still have patent anastomosis, then nobody knows what's best. And the danger is that what we don't know is if you have the first one delivered and you wait a couple of minutes to clamp the cord, then maybe in the meanwhile, the second twin that is inside the womb, that's the danger, can maybe lose blood inside the circulation of the first one. And actually last week, somewhere in the Netherlands, something like this happened, in which the first one baby was unexpectedly polycythemic and the second one became very anemic, and we had a big discussion whether this could have been due to intrapartum transfusion due to the delayed cord clamping. And we really don't know enough about this. In TAPS cases, I don't think there is a danger of acute transfusion from one baby to the other, because we know that it's only small anastomosis. So I would not think that that is important. And I would advise to do the delayed cord clamping, especially in the anemic one, who's the one who would benefit from maybe more placenta blood transfusion.
Okay, great. Thank you so much. I think we need to finish, and I'm just going to finish with one final point, because there's some question about management. So when do you expect a management when you intervene, and also sort of among the management options, because we do have the ongoing randomized control trial, but obviously will take time to get the result. I'll tell you what we do in my practice, and maybe also to hear comments from the Dutch team to see whether they agree or they do something different. So certainly stage 1 is expectant management, because some of them will go back to normal, and to be honest, you cannot justify intervention, because any intervention has potential risk. Certainly stage 3 or higher, we definitely do intervention because there's evidence already of compromise of one or both babies. Stage 2, it depends on whether how easy it's intervention, depends on the gestational age or so on. But certainly stage 3 or higher will be an indication for intervention. Stage 1 or 2, sometimes we monitor. Stage 1, definitely monitor. Stage 2, maybe intervention or monitoring. What type of intervention? It depends. So if you have a pregnancy, monochorionic diameter twin pregnancy that at 32 weeks and you have TAPS, I think it's reasonable to give steroids and plan delivery. If it is, at 18 weeks and you have stage 4 and one baby is hydropic, in this case, I think it's reasonable to consider the option of selective feticide. But certainly, I think the commonest option or the commonest intervention that we currently are offering is laser. The treatment, the same technique as for TTTS. Transfusions, very selected cases, maybe when relatively late in pregnancy, when maybe laser is not technically feasible, like anterior placenta, 28 weeks, where you don't want to deliver because of the prematurity, but also you need to do an intervention, and therefore maybe intrauterine transfusion with exchange transfusion is an option. Femke, do you want to have comment? You have the last word. Do you want to comment on that? I'm gonna unmute you 1 second. I'm sorry. I don't know why I find you again. Here we are.
Yes, thank you. We regarding the stage, we do treatment for the trial. We already do it from stage 2 onwards. And I think it's important also to look for additional signs. It's not an inclusion criteria for the trial to have additional signs, but we do sometimes see severe cases that are only stage 2. So it's not always that you see Doppler abnormalities like ductus abnormalities before to be severe anemic. And before you become hydropic. So sometimes we do offer a treatment in stage 2 onwards. And I can imagine, well, your thoughts and your ideas about offering laser or offering selective reduction. And it also, I think, has to do with the geography of your country and whether your patients are referred back or whether your patients come only for the treatment and then they go back to the referral hospital. I think that also influences the treatment that you choose, because of course later on, and if laser is not feasible anymore and you want to prolong the pregnancy, you might offer intrauterine transfusions, but you might need to do that repeatedly. Well, if you could do a laser and the treatment is complete and you find that the only residual anastomosis or the initial anastomosis in spontaneous steps, then you can might be able to refer the patient back, which is easier. I think we don't have sufficient data yet, and there's no evidence yet that laser is better. Of course, just by the idea that you treat the cause of TAPS, I can imagine that you prefer to do a laser, but we still don't know yet. And if you look at laser, your mortality rate might be higher than in IUT cases. So I think we really need this randomized trial to look at this. And the reason why we included from 20 weeks onwards, if you're below 20 weeks, then it's quite hard to do an intrauterine transfusion. And then you need to do it very, very often to reach a gestational age where you can deliver the children. So very early severe cases, of course, I think you should offer laser treatment. But the other thing is there's still, I think we need to, like we said before in this webinar, like TTS, we know it's stage 1, 2, 3, and we know the severity of the disease, and we know the outcome related to the diagnosis. In TAPS, there's still very much research to be done to see and to tell whether stage 1 and 2 are less severe compared to stage 3 or 4, for example. And as we stated before, there are cases with neurodevelopmental impairment and with deafness with only stage 1 or 2.
Thank you so much. I mean, on this note, I think just I'm reading a comment from Enrico Leprori about this point of deafness, and he's saying, well, he's not really sure that just because of prolonged fetal anemia, because we don't see a similar high risk of deafness in fetal anemia due to rhesus alloimmunization. So we don't really have enough data. We need more research, and it might be a combination of chronic growth restriction in combination with chronic anemia. So on this note, I would like to thank all the speakers. I'd like to thank Enrico Leprori for joining us and for his input, and for all the people who have attended the webinars and had all these questions and comments. I certainly learned a lot, and I enjoyed the discussion. So thank you very much. I hope you enjoy the rest of the weekend. The next webinar will be on the 28th of November, so in 2 weeks at 11 o'clock London time. And it's going to be mainly focusing on genetics and the challenges in genetic testing in multiple pregnancy. And we're going to have Tessa Humphrey, who is a consultant clinical genetics at St. George's, who is an excellent speaker. So thank you very much. I said, I hope you enjoy the rest of the weekend. And thank you. Thank you for being with us today.
Thank you very much, Asma.
Thank you. Bye-bye.
Thank you.
Thank you. Bye-bye.
Bye.